Hello people, this is Dr. Muskaan this side, and today I'm going to discuss one very beautiful case. It is all about upper GI bleeding. Let's go deep into this case and enjoy. Here is 46-year-old female who has came to ER with chief complaint of ghabrahat, red color urine, vomiting which is filled with blood since morning. So what are the differentials of red color urine? It can be some disease due to which there is some bleeding. It can be porphyria. It can be some medication such as rifampicin or phenytoin which is causing red color urine. It can be some food such as beetroot which can cause red color urine. Now on arrival, ABCS was done, that is airway, breathing, circulation and sensorium. Airway was patent. There was no signs of airway obstruction. What are the signs of airway obstruction, my dear friends? Choking, dysphagia, dysphonia, stridor. Patient is holding, is like, I'm not feeling like breathing. He's doing like this. When he walks or when he lie down, he's not feeling like breathing. सांस ही नहीं आ रही. That is airway obstruction signs. And when the airway obstruction is present, we generally intubate the patient. But in this patient, there was no signs of airway obstruction present. That means airway was patent. On breathing assessment, respiratory rate was 18 per minute and SpO2 was 98% on room air. There was no signs of respiratory distress. What are the signs of respiratory distress? Signs of respiratory distress is abnormal breathing, either too fast, either too slow, either too shallow, either too deep. Okay, it can be cyanosis, it can be pale skin, it can be gasping or gurgling sound, it can be fatigue or frightedness in the patient which is causing respiratory distress. And if respiratory distress is also present in the patient, we generally intubate the patient. But in this patient, there is no respiratory distress present. SpO2 or respiratory rate normal hai. Okay, on circulation assessment, pulse rate was 154 per minute and blood pressure was 90 by 70 mmHg. So this means there is presence of hypotension and tachycardia. That means in this patient there is shock. What is shock? Shock is there are 5 types of shock, and in that 5 types of shocks, all have hypotension and tachycardia except one shock, that is your neurogenic shock, in which there is hypotension associated with bradycardia. On sensorium assessment, GCI score shows 15 by 15 E4 V5 M6. That means eye was opening spontaneously, verbal response was oriented, and on motor response he was obeying the commands. So that means when I was checking A, B, C, S, everything was fine except C. C was circulation. हमने A क्यों चेक किया? ताकि we can see airway obstruction. हमने B क्यों चेक किया? ताकि हम respiratory distress देख सकें. C क्यों चेक किया? ताकि हम shock देख सकें. और S क्यों चेक किया? ताकि हम Glasgow Coma Scoliosis की altered mental status है कि नहीं है वो देख सकें. HOPI, patient came with the complaint of hematemesis, that is vomiting associated with blood, है ना? Since 7 a.m. in the morning, there were 5 to 6 episodes. The vomitus did not contain any food particle. It was 150 to 200 ml in vomitus. It was associated with melena, red color urine, retching. Patient was also feeling pain in abdomen while vomiting. Negative history. There was negative history of chest pain, shortness of breath, fever or chronic NSAID use. Past history. There is no comorbidities like type 2 diabetes mellitus, hypertension, thyroid, epilepsy, TB or TB contact. Personal history. Patient is alcoholic since 6 months, 1 quarter daily he drinks. Last intake was 3 days back. There was no addictions of smoking and hookah. Appetite is reduced and sleep is normal. Bladder habits, there was burning micturition and red color urine. Bowel habits, melena since today. General examination, BP was 90 by 70, pulse rate was 106 per minute, respiratory rate was 19 per minute, SpO2 was 98% on room air. Out of this, there is presence of tachycardia and hypotension. Systemic examination, CVS was S1, S2 present, respi bilateral entry present, CNS 15 by 15, GCS score. Per abdominal examination, there was epigastric tenderness and there was no hepatomegaly. Now, I want to tell you difference between upper GI bleed and lower GI bleed. In upper GI bleed, bleeding is above the ligament of teres, which is upper GI bleeding. And in lower GI bleeding, bleeding is below the DJ junction, which is lower GI bleeding. In upper GI bleeding, there is hematemesis present, that is blood in the vomitus, and there is coffee ground emesis, vomiting of dark gastric acid. Okay, and there is melena, which is black taste stools. But in lower GI bleeding, there is hematochezia, which is passage of free blood in the feces. Okay, So what are the differentials of upper GI bleeding? First is alcohol abuse, second is esophageal varices, third is malignancy, fourth is malarious tear, fifth is Helicobacter pylori infection, sixth is peptic ulcer disease. These are the differentials of upper GI bleeding. Investigation picture: CBC shows anemia, leukocytosis. KFT picture shows hyperuremia. LFT picture shows hypoalbuminemia. HBS, AG, HCV, HIV 1-2 was non-reactive. Ultrasound report shows hepatic echo texture. Endoscopy report shows malarious tear. Because this patient was having positive history of alcohol intake, and after alcohol intake there was retching and he just vomited out in the morning and it was acidic with blood. So when I asked the personal history of this patient in detail, he told me that I do not drink, but I have started drinking because of bad company in last 6 months, and when I have started drinking, I am drinking it too much that it is not in my control. And last night when I drank alcohol, it was just split from my mouth, and there was some colicky pain in the abdomen, and the vomitus was associated with blood, which was 150 to 200 ml. And this is the classical history of malarious tear, that in this it occurs in alcoholics and there is sudden retching. Okay, so management: injection AMSET was given to prevent the emesis. Injection TIM was given, which is the treatment for vitamin B1 deficiency. Syrup sucralfate is given, which is treatment of acidity. Injection monocephalus is given, which is antibiotic to treat the bacterial infection. Tablet Librium was given, which is benzodiazepine, which is to treat the anxiety. So this is so beautiful case है ना, अपर जी आई ब्लीडिंग का है, इतनी प्यारी हिस्ट्री है, डायग्नोसिस है malarious tear का कंफर्म्ड हो गया एंडोस्कोपी रिपोर्ट से भी. नाउ आई एम गोइंग टू टेल यू अ लिटिल अबाउट malarious tear before ending this video. Malarious tear is a longitudinal tear. It starts at GE junction and proceeds towards cardia. Most commonly it is mucosal. Sometimes submucosa is also involved. Clinical features is seen in alcoholic patients, seen after forceful vomiting. Diagnosis: upper GI. Endoscopy: vessel implicated is left gastric artery. Management is usually self-limiting. Angioembolism or cauterization is given if it persists. So that's all. I hope you have really enjoyed listening to this case history, and I hope I have added some knowledge to your brain as well. That's all. Bye bye. Dr. Muskaan is signing off now.